All right, thanks so much, Dr. Davis and Dr. Ito. I think it was so helpful to review the clotting cascade and our principles of hemostasis, and also to get an overview of the different products that are out there. And that's just really a comprehensive approach to consideration of using these agents. But I also kind of want to give a little bit of a practical approach to how do we really decide what factors come into it when we're in the operating room and we're considering using one of these agents. So we're going to sort of walk through what are the most important clinical factors to consider when you're choosing which agent you might use. And so one of those first factors that we want to talk about is the type of surgical procedure. So THAs differ in their composition, and this affects how they work. So for example, fibrin sealants with high fibrinogen concentrations may produce a stronger but more slowly forming clot, whereas those with high thrombin concentrations, though they're rapidly forming, are less resilient. So familiarity with the products is going to come into that, but you also need to consider what is the need of this particular operation. For example, if you're doing a laparoscopic procedure, you need to consider how you would apply the agent. What's the method of application? Another important thing to consider is what kind of experience has been previously described for this particular THA. So for example, many of the THAs have been described for use in general, hepatic, orthopedic, or cardiovascular surgery, but perhaps maybe they haven't been described for use in ophthalmic or neurosurgical operations. And so some of these may even have a caution for particular types of surgeries, and these things need to be considered. Also, is the operation that you're doing the definitive operation, or do you plan to return? Some of these agents should be removed, and some can be left in place. So these are also important considerations. And then finally, if you're considering using a blood-saving device, such as Cell Saver, THAs should not be administered systemically. And so use of particular THAs, such as powders, in the setting of a blood-saving device may put the patient at risk for administration systemically. So it needs to be considered. Many THAs have certain niches, and so powders, for example, have been demonstrated to have a drying effect on the field and have frequently been used for operations such as lymph node dissections and prostatectomies. Flowables have often been used in ENT surgery and spine surgery, and this is likely related to the ability to get into small cavities with these agents. Fibrin sealants have been used pretty broadly across orthopedic surgery, cardiac surgery, and for liver and colorectal surgery. And then physical agents similarly have been around for a very long time and used broadly through many types of surgeries. Patient characteristics should also be considered when selecting a THA. So for example, if a physical agent is to be used, then the patient's coagulation pathway must be intact. Conversely, if the patient has an impaired coagulation cascade, but adequate fibrinogen level, then thrombins or flowables would be more appropriate. Finally, for patients who have coagulopathy and hypofibrinogenemia, fibrin sealants are uniquely useful. And thrombins and flowables are less likely to be effective if the patient has hypofibrinogenemia. Another factor to consider when selecting a THA is the hemorrhage site. Physical agents are useful for control of capillary venous and arteriolar bleeding. Flowable agents are particularly effective for localized bleeding. Thrombins can be applied, as Dr. Ito described, with gelatin sponge or with oxidized regenerized cellulose, and they're suitable also for localized small vessel bleeding from capillaries and venules. Fibrin sealants or thrombin in spray application are suitable for broad surfaces that are oozing throughout. And then another factor to consider is the severity of bleeding. So physical agents are mostly effective for light bleeding, just sort of oozing or intermittent flow that can be seen throughout. An example would be rough surfaces after organ removal. Fibrin and active agents are useful for small venules and capillaries that are accessible. Fibrin sealant is particularly useful for broad, raw surfaces. And then flowable agents have a niche for irregular wounds or cavities that they can be injected into. It's also important to consider the accessibility of the bleeding site. So bleeding from diffuse raw surfaces with multiple points of bleeding. Again, powders are particularly useful for this, or fibrin sealants, because they can cover a broad surface area with diffuse bleeding. For bleeding close to the bone, it's important to avoid physical agents because they can inhibit bone healing. For bleeding around delicate structures such as nerves, physical agents should also be avoided because they lead to fluid resorption and swelling, which can impinge upon these important structures. For needle hole bleeding, physical agents are often a preferred or suitable agent because they're absorbable. And then finally, in irregular wounds or cavities, as previously mentioned, flowables are particularly amenable to this kind of bleeding site. You can also use powders, which have good adherence and distribution in the right proportion for irregular surfaces, but it can be sometimes more difficult to apply these in these kinds of locations. So I think it's helpful when considering all of these factors to apply them to a case presentation. So in this case, we describe a 46-year-old female who is a Jehovah's Witness who undergoes laparoscopic interval appendectomy after a perforated appendicitis several months ago. After the cecum is mobilized and the appendix is removed, you note that she has diffuse oozing from the retroperitoneum, which is packed. After the packing is removed, you consider using a THA. So I want to ask my colleagues if they have any sort of preferred THA that they might use in this situation, or what kind of factors, as we've previously described, they might consider when selecting a THA in this case.
Tracy, do you have thoughts?
While I don't do appendectomies, I would imagine that in a similar situation, I would use a flowable. Laparoscopic application of a flowable is very pertinent and very easy. It seems like all the circulating staff know how to do it at this point. So I would choose a flowable in this situation. How about you, Dr. Davis?
I fully agree. I think this is a problem that I see more of than I would care to admit, perhaps. And I break out, for lack of a better way to state it, all the seals, the flow seals, the TIS seals, everything to try and stop that annoying ooze from bad dissection back there, for sure.
Yeah, and I think that this is a really good case to consider because I think it's important to note that there's no one particular agent that really is the only agent or the preferred agent. And I think everybody has their own style to how they consider those factors. But again, I think a flowable it would be a good one to consider in terms of the ease of use. And the coverage of this degree of bleeding. And you also might want to consider a powder, which also I think would apply across a broad surface pretty well and might be another acceptable alternative. For patients who are Jehovah's Witness, it's important to consider the composition of these THAs because some of them do include either human blood product or animal product components. So these are just all considerations that should be taken into account when selecting an agent. For best practices, when using THAs, we also want to consider some things other than patient factors. There are 6 performance factors to assess when selecting your THA. And one of the most important ones, of course, is safety. So there are a number of safety cautions associated with use of these agents. Patients receiving thrombin-containing products should be monitored for signs of hypersensitivity reactions. And of course, infection is an important consideration postoperatively for any of these agents. Other than safety, the particular agent's efficacy should be considered. We've talked before about what kinds of cases have these previously been used successfully in, and I think that that's an important consideration. We should also consider the preparation of the product. Some products are more effective if frozen or refrigerated, such as thrombins. And so you want to think about your particular setting and storage capability. And then you want to think about the ease of reconstitution, thawing, mixing, and delivering these agents. All of this, as well as the usability. Are you going to be using this laparoscopically? Are you going to be using it in an open case? And then probably one of the most important factors is the cost. There is quite a big cost difference between physical agents and active agents. Active agents, though more effective, are significantly more expensive. And so this should weigh into your decision-making process. And then finally, ensuring that the products that you're using have been through the appropriate FDA approval process. So in summary, THAs are not a replacement for good surgical technique, nor do they replace traditional methods such as mechanical, thermal, and chemical control of bleeding. When selecting a THA, clinical factors such as the type of surgery, the patient's coagulation status, and the site and accessibility of bleeding should be considered. Performance factors of THAs, including the cost, the preparation, and safety, are also important. So things that we should think of as definitely doing: we should use THAs as an adjunct for diffuse bleeding over large surface areas. We should use THAs to aid in hemostasis in hard-to-reach areas. And we should use THAs to slow bleeding in areas of sensitive structures where electrocautery may be contraindicated. On the reverse side, we should not use THAs as a substitute for surgical hemostasis with clips, sutures, and cautery. We should not pack THAs in areas where nerves or sensitive structures could be harmfully compressed. And we should not leave more than necessary quantities of THAs because that can lead to complications such as infection.